welcome back to the Peer Perspective Podcast. I'm your host, Calvin Blaircom. Today we're joined by Dr. David Frenz, the Chief Medical Officer at Osceola Medical Center. He's a board-certified expert in addiction medicine with a deep understanding of how substance use affects individuals and communities. In this episode, we talk about the soft stigma, as he calls it, associated with medication-assisted treatment and why it's time to shift the narrative. He also shares some of the trends that he sees in the field, both locally and nationally. And then we dive into some exciting news about new programming at Osceola, how they're trying to meet people exactly where they're at in these rural communities. Whether you're in recovery, working in the field, or simply care about what's happening in your community, this conversation is one you don't want to miss. Without further ado, here's Dr. Frenz.
Okay. Well, appreciate you having me.
Absolutely.
Again.
Yeah.
And I made it on time. I was a little worried that I wasn't going to.
The bridge.
Yeah. I appreciate you having me at your office. We're in Minneapolis at the Medical Arts Building. Okay. And you were actually recommended. So Dr. David Frenz, you are the Chief Medical Officer at Osceola Medical Center.
Correct.
Board certified in addiction medicine.
Yes.
And you sent me an article or a blog post which kind of encompasses your approach, I think, and we'll get to that in a little bit. But so Penny, one of my previous guests, actually highly recommended you, and then I had a nice conversation with your wife, and she filled me in on a couple of things. But you've been doing this a long time.
Since 2005.
So, and maybe that's a good place that we can start is, part of the purpose behind this is I've found, we have people with lived experience, and then we also have people that have a passion for helping people. And so I'm always interested to find out, why people do the work that they do. So maybe you could start there
How I wound up in addiction?
Yeah.
Yeah, right. That's a good question. I mean, everybody goes into medicine to help people.
Sure.
And throughout my training, I became really interested in people with mental illness and addiction. Mm-hmm. And I was on a family medicine training track. Mm-hmm. And I completed my training in family medicine, but through the fairly long training cycle, I kind of recognized that I wanted to incorporate that somehow into a family medicine practice.
Sure.
I wasn't quite sure how to do it. And when I was a resident at the University of Minnesota, at that time, they would send residents to Hazelden, the Center City campus
sure.
of Hazelden, for a week.
Been there.
Yeah, right. Yeah, I was there as a trainee, not a patient. But they had a program at the time called Professionals in Residence Program. It was a Monday through Friday, full days sort of thing. And that, I think, was the real turning point for me. It's like, wow, this is amazing. And there was stuff going on in my personal life as well. My dad was in the clergy, and so very interested in spirituality.
Sure.
And addiction medicine not only was fascinating medicine, but it was an area that intersected with spirituality. Who am I? Why am I here? What should I be doing?
Right.
Those sorts of questions.
Right. And you kind of have, I don't know if it's the focus of your practice now is an opioid addict.
Yeah, well, alcohol's still public enemy number one.
Sure.
If you kind of look at the prevalence of it.
Especially in Wisconsin. I kind of lived a lot of the opioid epidemic. Sure.
It began in the late 90s when I was first training, and it exploded in the early 2000s. And so just kind of by accident, I had an opioid-focused practice just because there was so much opioid addiction.
So in that blog post that you sent me, you kind of talked about kind of your approach to medicine. Can you kind of, I guess maybe talk a little bit about that and how you try to encompass the whole person, or I think you mentioned how it's not just the medication, there's so much more to it, and you kind of talked about that with the spirituality piece, but kind of your perspective on that.
Yeah, I believe, and I think I'm pretty well supported by the evidence that substance use is a symptom, and our job is to figure out what the driver for the symptom is. And so I use a metaphor a lot. Fever's a symptom. And you can throw Advil at fever, but it's not a very good play because you're not addressing the underlying driver. And so Advil may knock down the fever for a while, but if there's an ear infection, the fever will pop right back up again.
Right.
And so my approach is to look for those drivers. And so often substance abuse treatment is focused on the substance use disorder,
Right.
and trying to render people abstinent from their substance. And relapse is so common because really the underlying driver hasn't been addressed. So it's
Right.
again like fever. We tamp down the substance use disorder through treatment focused on that, but there's this substrate that's still there, whether it be an underlying anxiety disorder, so often it's personality structure.
Right.
And so that's my approach, is to find the driver and work at the driver.
Yeah, and I mean, from my perspective as a peer support, I think that's so important. Like, I mean, my experience with going to the doctor and all that, I got prescribed Adderall at a very early age, and it became a problem. And you mix that with alcohol, and it just was kind of a downward spiral for me. And so, I had to take medication. Actually, at Hazelden, they gave me some naltrexone, which was helpful. Well, I don't know if it was helpful or not, but I didn't want to stop taking it. I was able to kind of get off of that, and my recovery is, but there's a lot that goes into it. It's not just the medication, So it's nice to hear that. What brought you to Osceola? Because you were from Minnesota, right? You live here, and
I do, and I've practiced in various health systems
Sure.
in the Twin Cities, and also a health system up in St. Cloud. I followed one of my mentors, so Kelly McInmarble, who's the CEO.
Okay.
I've worked with her in a number of health systems. I worked with her at Health East, which has since been absorbed by Fairview, worked for her at North Memorial, and then up in St. Cloud at CentraCare. And so I think the world of her. She left the region. She was working in Indiana for quite a while as a CEO of a big physician group out there. But then she decided that she was sick of commuting because she was flying back and forth.
Oh, wow.
Yeah.
Wow.
And she reached out and she's like, "Hey, I'm back. Do you want to get the band back together?" Essentially, and it was a super cool opportunity. I love the smaller size of Osceola.
Yeah,
I've worked in big health systems. I've appreciated working in big health systems, but smaller organizations, it's easier to do stuff.
Yeah.
And the other thing that was intriguing to me as an addiction provider is there was no mental health or addiction services at Osceola.
Yeah. Yeah.
So there was no therapists, there was no prescribers, and so I like program starts.
Yeah.
And so the opportunity to spin up mental health and addiction services locally in Osceola was very attractive to me.
Yeah. Yeah. So how long have you been there?
March of 23.
Got it. Okay.
Yeah, a couple years.
Yeah. Yeah. And so since then, you've been able to kind of start this program essentially, and that's awesome. Yeah, and there's such a need. I feel like in these smaller communities, a lot of times it feels like they get overlooked, and they lack the resources. And I know I'm from River Falls, which is a little bit bigger community than Osceola, but like I shared with you earlier, my wife and her family are from Osceola, so it's, that's great. What kinds of things, it sounds like you started this program at Osceola, but like, what do you see for the future for, Osceola Medical Center?
So right now, all of our services are office-based.
Sure.
And so we have a therapist and 2 prescribers, but we don't have groups. And so we're actively pursuing starting an intensive outpatient program, an IOP.
Oh, wow.
Right. That would be an important asset, I think, to the overall recovery offering that we have. And we hired a therapist to run mental health groups. And so those will be coming as well. And so in addition to sort of one-on-one individual treatment in office-based settings, we'll be able to have the group situation. The other thing that we want to do, you might be aware we're doing a campus expansion where we're adding on a ton of...
No.
Yeah, so Osceola Medical Center is currently in the middle of a $20 million campus expansion.
Wow.
Yeah.
That's awesome.
And so with the addition of new space is new possibilities.
Right.
And it would be nice if we could become sort of a place where community members could run meetings.
Yeah.
You know, provide a space at no cost. You know, so if they want to run AA meetings, NA meetings,
Yeah.
you know, be a public space where they could do that if they want.
Oh, that's great. Definitely a need there. I know. I don't think Osceola has anything like that right now.
I think there's a meeting at a church
Okay.
that I've heard of. But
Got it.
yeah, I mean, I think being able to couple that with professional services would be important to us.
Well, so more to come on that.
Yes.
Can you talk about some of the unique challenges that folks in rural communities, especially at rural hospitals, face, and kind of what, I know the landscape is a little bit different than, say, Minneapolis or something, and we talked a little bit about that earlier, but...
Yeah, I mean, it's true of, I think, every condition, not just mental illness and addiction, in that typically the experts are in larger cities.
Right.
And so the challenge I think people in rural areas face is the travel to get to care. It's one thing to travel to the Twin Cities to see a neurologist periodically, but with addiction treatment, the intensity of care is greater.
Right.
And so that distance is a bigger problem. You know, it would require a lot of commuting. And so that's a unique challenge, is bringing the care locally.
Right.
To eliminate that. You know, another thing that we talked about previously is some patients need stabilization. And so, for example, they need to be withdrawn safely from alcohol. Sometimes you can do that as an outpatient. You know, patients who are lower risk and reliable, you can do an outpatient detox. But some patients, they just need to be in a monitored environment. In bigger cities, there's county detoxification facilities.
Right.
Polk County doesn't have one. You know, I reached out to them. I'm like, hey, what are my local resources? So there's no county detox facility. I asked them if they partner with other counties, because sometimes counties band together.
Sure.
And have a shared resource. And they said, nope, we don't have any sort of partnership with any other county on that. We just send people to the hospital. And so historically, we had not admitted patients to the hospital for withdrawal.
Right.
And that's changed. We recognize that people come to our emergency room either for their problem with substances or it's a secondary problem.
Right.
You know, they injure themselves while they're intoxicated, for example. And so now we do admit patients to the hospital for medically managed withdrawal.
Wow.
Which for many patients is the beginning of their recovery.
Right, right. And I mean, we talked about that, what a scary moment, but it's in many cases a brief window, you know, where people can get help and are willing to get the help. And
right.
So that's...
and that's why IOP is kind of important to us, because in Polk County, there's not a good step-down option. So we can admit people to the hospital, withdraw them from alcohol. I mean, typically you would step down either to residential or you would step down to IOP. Without those assets or resources, it's a big step.
Right.
It's a step from the hospital down to office-based care, and there's that gap. And so that's why we need IOP, is to step them down to more intensive treatment following hospitalization.
Yeah. So important to be creative in these situations where we're, you know, lacking. And, you know, I shared with you that's part of what this is all about for me, is being able to connect with people and learn about these projects that are going on. And
know your resources.
Yeah, and I had no idea that, you know, that was even an option. And so what a huge resource that is for people, because I've had a few situations recently. Can you share maybe an experience or a success story or something that you've kind of seen because I know you take patients here. Do you take people in person at Osceola?
Oh, for sure.
Oh, okay, okay.
Yeah, so there's two of us doing in-person, face-to-face care like this.
Got it, okay.
And then we have a teletherapist, although that's going to change. We've hired a therapist who's going to be on site.
Oh, nice.
Yeah,
Okay, great.
it was amazing. Lives locally
Mm-hmm.
and has experience and is going to join us later this year.
That's great.
It is great, and so yeah, it's our preference.
Great.
You know, I mean,
Yeah.
sometimes you have to use technology because of distance and stuff like that. But I personally think in-person visits are a little higher quality.
Yeah, yeah.
In terms of successes, I would say across my practice career, opioid use disorder, opioid addiction went from being hopeless to almost the easiest addiction to treat.
Mm-hmm.
I mean, it's a very consistent theme. Before Suboxone was approved in 2002 for use in the United States, your only option really was methadone.
Right.
And methadone was only available in large cities, so getting back to the urban-rural divide,
Right.
People in rural areas couldn't access it. And then because of all the federal rules surrounding methadone, even if you could access it, say you lived in a big city and there was a methadone clinic available, because of the federal rules, you had to go in person 6 days a week, your first
Right.
90 days on program. It became very difficult for people to sustain that and hold a job and
Right.
Stuff like that.
Right.
So when Suboxone was approved in 2002 in the United States, it changed everything. People suddenly had access to a very effective medication. You didn't have to go to special clinics.
Right.
You could get it through, your
primary
primary care provider.
Sure.
Yeah, and so it's a pretty consistent theme, and I mean, really remarkable.
Yeah.
Like,
Yeah.
it was one of the hardest things to treat,
Yeah.
and now it's frankly one of the easier addictions to treat.
Have you seen any change since, I mean, fentanyl is a thing. Have you seen any, I don't know, changes since that's become a thing? Or
Yeah, for sure.
Okay.
If you kind of trace out the opioid epidemic, a big part of the problem was providers.
Right.
We were prescribing pills, and everybody's really buttoned up on that. Opioid prescribing is much more judicious now. And so it pretty much forced patients or people to find illicit sources.
Yeah.
So that's where fentanyl kind of entered the picture. And like I tell patients, there's very few second chances with fentanyl.
Right.
Early in my career, when people were using heroin and pills, you might overdose, wake up a few hours later, but survive.
Right.
Right?
Right.
And now sometimes the first overdose is the last overdose, so the stakes are much higher with fentanyl. So that's been a big one.
Yeah, I feel like it's become too frequent that, people in our small communities, we've experienced a lot of loss,
Yeah.
recently. And, it's unfortunate. I guess my question is, what would you say to the family members or even the people that are struggling that are, what would you say to somebody who's...
I mean, get on Suboxone as fast as possible.
Yeah.
Yeah, and our goal is to make the barrier pretty low.
Okay.
Yeah, it shouldn't be a big production.
Yeah. Yeah.
So, I mean, if you're struggling, seek Suboxone and get on it right away. We have decades of research
Yeah.
at how effective it is at basically vastly reducing, if not eliminating, opioid use.
Yeah.
And the evidence is clear. It prevents overdoses. It prevents overdose deaths. And so I would say, seek it. There's still what I call a soft stigma around medications, particularly in the Midwest. Sometimes that's something that patients struggle with. Actually, one of my patients wrote a book about this.
Oh.
I'll hand you a copy on the way out.
Yeah.
Yeah, just that soft stigma.
Yeah.
It comes honestly from some confusion around how to treat addiction. The cardinal feature of diabetes is high blood sugar, but I think people recognize there's various forms of diabetes.
Sure.
There's type 1, you don't make insulin. There's type 2, you make a lot of insulin, but your tissue doesn't respond to it. There's diabetes in pregnancy. So even though they all have high blood sugar as their primary manifestation, you have to treat them differently. We've been slow to recognize that for addiction.
Right.
And so it's like, what is addiction? Well, it's problematic substance use despite consequences.
Right.
Just regardless of which substance it is. But really how those addictions behave is very different from substance to substance. And so an abstinence-based, medication-free treatment approach for alcohol generally works well. It doesn't work well. It's never worked well for opioids. But people sometimes get confusing messaging, even from addiction professionals, and so they're reluctant to take medications for that reason.
Obviously, I work in the field, so
Yeah,
I'm a huge, I support people in whatever that pathway looks for them.
It is their choice. I mean, I will sit down and lay out all the options, including non-medication treatment. Most patients have never had what is called a really good informed consent discussion. Like, here's your illness, here are your treatment options, including no medications. Here are the benefits and the negatives of each treatment option. Which one makes the most sense for you? And then ultimately, they get to decide. I don't decide for them. I will say after an informed consent discussion, most patients are like, yeah, I'll take Suboxone. And then the very next question is, do I have to take this forever? And I'm like, I can't think of forever.
Sure.
I can barely think of, next week. And I tell them, look, let's just see where this leads us.
Yeah.
And we'll reevaluate at every step along the way. And if this medication no longer makes sense for you, we can always change your treatment plan. But really the priority is to stabilize you and prevent something really bad from happening while we figure out your future.
Right. Do you feel like it's a common conversation that people have, or a goal that they want to discontinue the meds? Or
they often have that goal on the front end. I will tell you that very few patients, and it's always on the table.
Yeah.
It's always on the table. Very few patients wind up deciding to taper, and usually what happens is after about a year on the medication, they look back on their life and they're like, wow, I'm in a very different spot compared to where I was.
Yeah.
I now have stable housing, I'm employed, my relationships are good. They kind of say, like, I'm not sure I want to mess with success.
Right.
And honestly, the studies would say that most people don't do well if you taper them off. There's a lot of studies on what happens. And you can taper people incredibly slowly over many months. The outcomes are still not very good.
Okay.
Because we're dealing with a chronic brain disease.
Right.
And I think that's another misconception, that a lot of times addiction is thought of as like strep throat for the soul.
Yeah.
Right. And we'll give you acute treatments to help you get over your illness, but in reality, there's still a brain problem that the acute treatments don't fix and they'll never fix. And so most patients, to circle back on it, they don't want to mess with success.
Yeah.
The meds aren't all that expensive anymore.
Right.
It's a drag to see me a few times a year. Sometimes there's medication side effects. There's always that possibility. I'm really blunt with patients. Medicines are poisons. They interfere with the way your body's supposed to work. You may have side effects. Nobody really discontinues Suboxone, for example, over side effects. It's a pretty well tolerated medication, or we can work through side effects.
Well, I feel like compared to the other substances that they were on, maybe it's the lesser of two.
Yeah, right. And then again, my calculus has changed a little bit with fentanyl.
Yeah.
Because again, it's like knowing that the risk of overdose death is so great off of methadone and Suboxone.
Right.
I have to put that out there. Like, there may not be a second chance.
Right.
And if you prioritize being off medications for personal reasons, that's completely fine. I'll support you in that, but you have to know what you're dealing with. Yeah, you have to make an informed decision.
And maybe that's a good, I guess if you can kind of talk about the differences between like heroin, for instance, and compared to fentanyl. I mean, I know I saw like a graphic once, and it showed kind of a side by side, like in granular form, what it looked like, but you know, just the effect that I guess that it has on the body compared to heroin. And I mean, I don't think they even see heroin as much anymore on the streets.
I'm not sure anybody's actually using heroin, true heroin. So heroin comes from the latex of poppy plants.
Okay.
And it was the original opioid. It was a medicine in the 1800s.
Yeah.
And it became a drug of abuse, you know, along with becoming a medication. It's essentially morphine. Heroin's essentially morphine. And so I'm not sure anybody's really using true heroin like from poppy plants anymore. Their dealer may claim it's heroin, but it's probably fentanyl at this point. You know, the big difference is just potency.
Yeah.
I mean, fentanyl is insanely potent, you know, gram for gram or milligram for milligram compared to other opioids. And so that's why the margin of error is minimal. When we use fentanyl in medical context. So we use it for procedures. It's pretty common to give fentanyl during procedures. We use microgram quantities compared to milligram quantities of morphine.
Yeah.
You know, and so that's 3 orders of magnitude different. It's not just a little different, it's a lot different.
Yeah.
3 orders of magnitude. And so that's why the margin of error is so small. And you never know what you're getting. That's the problem.
Right.
I've been advising patients to use fentanyl test strips. You know, they're available. They're free. I don't know what you do with the outcome because I think everything has fentanyl in it now.
Yeah.
It used to be that you could test your stuff, and if it had fentanyl in it, you could avoid it. I'm like, oh, I won't use this.
Right, and now it's almost like people are seeking it out.
Right.
I mean, it's not.
Yeah.
You know, it's scary, and I just think about in my own active use and where I was at, and there's no doubt in my mind that I would be using it today if I was still you know, using drugs, and that's just, I think, the reality.
You don't have to inject anymore.
No, I mean,
you know, so
pressed pills and stuff.
They're pressed pills, right? So early in my career, you know, fentanyl or heroin was, you know, you had to inject it essentially. It wasn't very potent, you know, compared to other opioids.
Right.
And so you would have to, inject it for it to be effective, you know, because of tolerance. Usually opioid users became tolerant and they'd have to inject it.
Yeah.
You know, now you can just swallow a pill.
Right.
Yeah.
And I
so
feel
the barrier to use is lower.
Yeah.
You know, for some people it was a big jump to go from snorting or swallowing
to shooting.
Right.
Yeah.
That was a big jump for them, and some people that was a bridge they wouldn't cross. But yeah, now they don't even have to think about needles. They don't even have to think about snorting.
And I feel like, I mean, maybe that it might appeal to more people too. Like, I don't know, if it's in a pill, it just seems less intimidating, and also.
And they look very authentic. That's the other thing.
Like Percocet or something.
They're perfect. So, you know, again, early in my career, my patients would tell me, they were obviously fake. I mean, they were, you know, they were poorly manufactured. They were almost cartoonishly fake.
Yeah.
And I think the case that really brought attention to this, it was a Minnesota case. Prince died of a fentanyl overdose, but it was authentic-looking Vicodin pills.
Oh, wow.
Right, and so that was the first case of counterfeit pills that were almost indistinguishable. They were indistinguishable from real Vicodin.
Wow.
Yeah, and so now, I mean, they're made in labs. The pills are made in labs, just like pharma type labs. They look authentic.
Yeah, it's pretty crazy, and I know, you know, even for people that are experimenting or maybe buying illicit drugs that they don't think is fentanyl, you know, that's where the testing strips are really important. Because you just never know.
I think the hard part is that there's maybe a representation that it came from a pharmacy. You know, I have these pills, I got them from a pharmacy, or they came from a pharmacy. And by all accounts, if you use the pill finder, I don't know if you've ever used pill finders before. Yeah, I mean, if you punch in the
blue with this code on it, and that's what's going to come up.
It'll come up, but it's not.
Right.
You know, it's not 10 milligrams of oxycodone.
Right.
It's not, you know, oxycodone 10. It's Fentanyl.
What would you say are the biggest, I guess, misconceptions that you've seen, even from people that you treat, about addiction? Yeah, just about kind of the process or the disease itself, or
Yeah, it's that whole acute illness versus chronic illness sort of mindset. And I don't blame people. They come in, they're distressed, they're impaired, they just want the problem to go away.
right.
But that commitment to managing a long-term disease, much like you have to manage diabetes, there's no acute fix for diabetes. We don't have gene therapy yet,
Right.
Stem cell therapy yet. So I think for some people, it's like, yeah, this is more work than I thought it would be. So that's, I think, a hard one, is sticking with disease management. And it's true of any chronic disease. If you talk to primary care doctors about blood pressure management, diabetes management, it's we have really good treatments. It's just sometimes patients struggle to stick with those treatments.
Stay on it for the
Stay
rest.
on it, yeah. I mean, it takes time and commitment and.
I know from my own experience, there's a period of mourning where, like, you almost have to, like, find some acceptance with, I'm going to have to deal with this for the rest of my life.
Right.
It's not, just go to treatment and finish aftercare and get off the meds, and then I'm better.
I'm good.
It's like,
yeah.
So, it took me a long time, years and years and years to wrap my head around that. And I would kind of keep going back to that place and thinking, oh, I'm good now, and then it would just.
People typically are.
Yeah.
Right? I mean, but the momentum eventually stalls out.
Yeah.
All the recovery momentum stops.
That's exactly
and then you're back
Yep.
back in that same spot again.
Well, this has been really enlightening, and I know the people listening are really going to take a lot out of it. I guess I want to kind of give you this last opportunity if there's anything that you'd like to share, or I just want to give you the last word here.
Yeah, well, we've talked about alcohol and opioids, and rightly so, but I think a difference between rural and urban areas is stimulant.
Oh, yeah.
Stimulant addiction. Yeah, so stimulant addiction tends to be more common in rural areas as compared to urban areas. And so that's something that we see at Osceola Medical Center, is people abusing stimulants. The thing that kind of recently surprised me, I haven't seen this in years, is I've seen a few patients in Osceola who are using powder cocaine.
Oh.
Like, I haven't seen that for ever.
Yeah.
Yeah, so, crack cocaine, I assume they were using crack cocaine.
Yeah.
Right, when they established care with me, and they're like, oh, what are you here for? Cocaine. And I'm like, well, is it powder or crack? And they're like, powder. And I'm like, no, really? So there's very effective treatments for stimulant use disorder now as well. I think patients aren't aware of that.
Yeah.
So that there's been a number of studies, and there's good treatments for it. The fear I have with stimulants is the same one I have with opioids. There's probably fentanyl in it.
Sure.
Right, and it's like, well, why would they do that? That's not even my drug of choice. And I'm like, I have no idea.
Right.
These aren't like Harvard MBAs at pharma.
Yeah.
Right.
Yeah, it's interesting you say that. And actually, on my last relapse, we almost got like physically ill, and it was just kind of a weird, and maybe obviously we had no way to verify that, and it could have been just psychological.
I don't think so.
We felt, and I never felt that before. You know what I mean?
So a lot of people will have, standard opioid type side effects from the stimulants.
Yeah.
Nausea, itching.
Yes, that's exactly.
It's like, okay, that's not a stimulant.
Yeah.
Yeah, there was an opioid in there, and you gotta assume it was probably fentanyl. So I'm having those discussions with my stimulant users. I'm like, you have to assume that it's in there. Again, discussions about fentanyl test strips, Narcan. Narcan nasal spray being available. Never use alone. Sometimes that's not feasible, but there are phone numbers. I don't know if you're aware of these, the never use alone phone numbers. So if you are going to use the Never Use Alone phone number so that if you stop responding,
Yep.
they will send an ambulance.
And we can post that information in the description too.
Yeah,
just so,
that'd be great.
Yeah, it's a great resource to share with people.
I mean, preferably go get treatment and get on
Right.
get on effective medications, but like
Yep.
if you're going to use,
Yep.
mitigate as many risks as you can.
Or if you know somebody who's using, I mean, it's just
Yeah,
a
or
good
if you
thing
know
to pass along.
Right. So fentanyl test strips, Narcan nasal spray,
Yep.
Never Use Alone phone number.
Yep.
Yeah.
And I think you touched on a really, I don't know why I missed stimulants, because, meth use in our area is huge. I think Polk County for a long time was known as like the meth capital.
And it's back actually.
Yeah,
Because we did
yeah.
see a large decline.
Yep.
Because when they litigated, or when they put all the Sudafed behind the counter,
Right.
so domestic production became very, very hard.
Right.
It used to be they would just get a bunch of pseudoephedrine and do some magic
Yeah.
in a bathtub
Right.
and make meth out of it. So we saw a big decline, but then, it was flowing across the southern border essentially.
Right.
It was entering from non-domestic sources. Yeah, and it's more common in rural areas.
Yeah, I think on the news not too long ago I saw the
900 pounds.
900 pounds.
Meths, two of them.
Yeah.
Yeah, and I'm like, that is a remarkable seizure. So it's like, how many unit doses would 900 pounds be?
Yeah.
I mean, when you convert it down to like,
And how much did they miss?
they missed a ton. I'm sure.
Because if there's that much,
Yeah, right.
makes you wonder how much they didn't catch. So
Right. That's, I think, a good example of getting to the driver. It's like, well, why are you using stimulants?
Right.
It's seldom that a patient will say, well, I was using it to get high. They often were addressing stuff.
Yeah.
Like
That was my experience. I was prescribed something because it helped me to
cognitive
focus,
Yeah.
and I could no longer get that prescription because my physician was a little bit.
in light of your history.
So this is before the meth, but yeah, so cut me off, said I had to pass the drug test essentially,
Yeah.
and so I found the next best thing, and it was off to the races.
Right. So common story. So,
Yep.
certain occupations, stimulants are helpful.
Yeah.
Shift workers,
Truck drivers.
Yeah, exactly. And so, again, don't get distracted by the substance use.
Yeah.
It's like, I mean, that's a problem. I'm not trivializing it. It's a big issue. But like, why?
Right.
Why are you using stimulants?
Right.
Yeah.
So, you talk about how stimulants are treated maybe differently as far as like, obviously you're not going to take Suboxone if that's the issue, right?
Right. Different. Yeah, that's a great example. So, at the end of the day, it's problematic substance use despite consequences. But much like type 1 diabetics, you treat them, with insulin for sure. They need insulin. Type 2 diabetics, sometimes you can treat them with pills. So the whole treatment approach really depends on the substance.
Sure.
And historically, it was the treatment models were because alcohol was the thing.
Right.
Alcoholics Anonymous.
Right.
Which I'm a fan of. But so we tried to take that treatment model, apply it to other substances, really without a whole lot of success.
Right.
Yeah, and so.
Yeah, it's interesting, and I'm sure people will. It's just good to have this conversation because I think people. There is so much stigma, and I think we're moving in the right direction, and people are starting to come around to that idea. But I've been in rooms where those conversations are had, where it's like, oh, so and so's on medication, and so they're not really sober, or whatever it is. And I think, it can just be really harmful for people.
Yeah, well, I think at the end of the day, for me, the patient defines their path.
Right.
So take a guy with a trashed knee, bad arthritis. The surgeon will say, here's a bunch of options. You could take Tylenol. We can inject you. There's various forms of injections. Yeah. What makes sense to you? And so rather than imposing a paradigm on people, let them pick. But I know that's been hard because it gets really personal in a hurry because a lot of people in recovery their path has worked really well for them.
Yeah. Yeah.
And I'm happy if that path worked well for them. The reality is, though, is that path may not work for everyone.
Right.
And
Yeah.
to withhold effective treatment over basically what's a philosophy,
Right.
yeah, that's a tough one.
Right.
I do, you mentioned a really important point. This patients are often reluctant to share they're on medications at groups for fear of being sent away or
Yeah.
told that they're not really in recovery or that they've just traded one drug for another.
Yeah.
I think that's unfortunate.
Yeah. Yeah. I think that it's, I haven't heard of that happening, at least where I go to meetings, but, it's definitely still a thing, and I think we've come a long way because I think people are starting to see the reality of, the drugs that are available now, and, this is, I always look at it like, well, from my own experience, what works for me, it doesn't mean that it works for everybody. And I know a lot of people that have gone to church or they've, whatever that looks like. And so they found their way and I've found mine. And so
Right.
that I just have to.
I think we could, if you have time, talk
Sure.
just a little bit about this idea that you're trading one drug for another.
Yeah, of course.
And it's just not true. So, like, if you look at the diagnostic criteria for opioid use disorder, opioid addiction, there's 11 criteria. And if you apply those criteria to the medication that the patient is taking, none of them really are satisfied. They don't take more Suboxone than intended. They don't take, Suboxone's not interfering with their ability to be a parent, to work, right? When you kind of go through all 11 criteria, they really don't apply. And so you're not trading one addiction for another. You're not really trading one drug for another because the differences are really stark. It's like, well, tell me about your life on opioids. And they'll go down all 11. Like, my life was a mess.
Right.
Yeah, I often took more than I intended to. It totally messed up with my ability to function in society, et cetera, et cetera. So they had addiction, and now they don't.
Right. Right.
Right, and that for some that's a difficult bridge to cross. It's like, well, it's still an opioid, and their drug of choice was an opioid. And I'm like, I get that. I absolutely get that.
Right, right.
But, like, from a functional standpoint, like, it's hard to argue with what you're seeing.
Right.
Like, they have housing, they're working.
They have their kids.
They have their kids.
They're not
like,
on probation anymore,
right.
whatever that looks like.
Yeah. And actually the book I'm going to send you home with, that was a big part of it.
Yeah.
Coming to terms with that. He'd actually be a very interesting interview for you.
I was going to ask you.
William Cope Moyers.
Okay.
And
sure. Because I was still recording, I couldn't see the red light.
yeah, William Cope Moyers.
Okay.
He's completely public about his story in his book.
Awesome.
He identifies me as his doctor, so I'm not telling you anything that's not.
Okay.
Yeah, I'm not telling you anything that's not in the book.
Awesome.
But it's a fascinating read about.
Yeah.
Am I in recovery?
Oh.
I'm on this medicine that's totally changed my life.
Yeah.
Am I really in recovery?
Right.
And I can't answer that really for anyone.
Sure.
Because they have to define recovery for themselves. But I think it's the struggle with the outside voices.
Right.
Like, you're not really in recovery.
Right.
Because you're still on a pill.
Right.
When are you going to get off that pill?
Right. Well, that's. I think that's great. Maybe you could even talk a little bit about kind of the how Suboxone even works on the brain.
Right.
Because it's not. I think that's maybe a misconception too, that you can just take more and maybe get, feel a greater effect. I don't think that's how it works. Maybe.
No, it's not. So, the problem with opioid addiction is that the opioids that are abused don't last very long in the body. You consume them, they have an effect, they wear off, and you're on this endless cycle of using, up and down, up and down. You're going to have to take many doses of, say, heroin or oxycodone or whatever per day to feel halfway normal.
Sure.
Because you're always cycling. So the treatments for opioid addiction, methadone and Suboxone, they're very long-lasting opioids. There's really no up or down.
Okay.
Like once it's up to speed in your blood, there's not a lot of variation from dose to dose.
Okay.
And it's just sort of operating in the background, much like an antidepressant operates in the background.
Sure. Yeah.
People don't really feel anything. It's not like, I feel off, I better take my Suboxone.
Yeah.
Most of my patients are like, I don't feel anything.
Yeah.
It's just something that's part of my schedule. And I just take my meds on schedule. Methadone and Suboxone are a little different. So methadone, it's a long-acting opioid, but much like other opioids, the more you take, the bigger the effect.
Sure.
Suboxone's an odd opioid. It's called a partial agonist, in that there's actually a ceiling on effect. And no matter how much you're taking, it's hit the ceiling.
It's going to kind of cap you out.
It caps you out. And so, you can keep pushing the dose, and there's just really no added effect for that reason. Opioid tolerant people just don't really feel anything anyway.
Sure.
If somebody who does not take opioids was to take Suboxone, they might catch a buzz off of it. But opioid tolerant people, there's really no buzz to be caught.
Yeah.
So yeah, it occupies opioid receptors in the brain, and by doing so, it prevents withdrawal. It reduces cravings, reduces drug seeking.
Sure.
And actually the other important effect it has, although with fentanyl this is becoming a little bit questionable, it binds to opioid receptors very tightly.
Okay.
So that if another opioid came along, there's no receptor for it to bind to, and the other opioid can't muscle Suboxone off the opioid receptor.
Interesting.
Yes.
Okay.
Now, the hitch with fentanyl is that it's pretty close.
Sure.
In terms of its ability to maybe displace Suboxone. So it used to be it's called receptor blockade. So Suboxone and methadone offer receptor blockade. Back in the day when people were using morphine, you really couldn't overcome the receptor blockade. Morphine wasn't capable of displacing those medications from the opioid receptors. But with stronger opioids like fentanyl circulating, that's a possibility.
It can kind of knock that.
It could knock it out, yeah. There's also an argument that I find pretty compelling. You want to saturate as many opioid receptors as possible now so that there aren't empty receptors for fentanyl.
Sure.
Back in the day, we had a target dose, 12 to 16 milligrams per day of Suboxone was a pretty typical target dose. But that dose does leave a fair number of opioid receptors available or unoccupied.
Oh.
Some argue in the fentanyl era that we should probably occupy more receptors with Suboxone, so that if somebody tried to take fentanyl, that in theory at least there was fewer opportunities, fewer targets for fentanyl.
So essentially a higher dose.
A higher dose.
Okay.
Some argue that just because we know there's so much out there that you want to have Suboxone on as many receptors. So yes, higher dose to prevent overdose essentially.
Somebody said, maybe, or you can correct me if I'm wrong, but like even kind of getting through that like initial withdrawal, is that common to give someone a high dose so they can kind of get through that the sickness essentially?
Yeah, so that's probably another change that's worth highlighting. Early in my career, it didn't take all that much Suboxone to relieve withdrawal,
Right.
maybe 6 milligrams a day.
Because of the heroin.
Yeah, because of the heroin, and other drugs. With more potent opioids, higher degrees of tolerance,
Sure.
you can see more severe withdrawal syndromes. And so the doses that we might use for withdrawal now, might be quite a bit higher than what we historically used with more traditional opioids.
Sure. Yeah, it's all really fascinating. I feel like, I personally dabbled in opioids, many years ago, and it was nothing near what it is today. Actually, my biological father passed away. He had a long history with Dilaudid, actually, and he lived in Alabama, and so just across the border there was pill mills in Florida.
Yes, Florida was notorious for them.
And so he, was addicted and you know, with other things too, alcohol, and I think he actually died of a grand mal seizure. Did I say that right?
Mm-hmm.
But he had a long history with that, and but so I kind of dabbled, but it was yeah, I just couldn't imagine, and I've seen firsthand how sick people get, you know, without it, and it's just devastating. So, Dr. Frenz, I really appreciate this. This has been a great conversation.
Yeah, thanks for making
and
the
I'm
trip.
Really, yeah,
Yeah.
I really am looking forward to sharing this and sharing about the work that you're doing at Osceola Medical Center, and just kind of having that resource in my back pocket. I've been kind of mulling over that while
Yeah,
we're
we
talking.
can give you the phone number for the mental health clinic to put in
Yeah.
The comments.
Sure.
So I mean, you don't have to go through a telephone tree. It actually rings the department.
Oh, that's great. Okay.
Right, and
Yeah.
so, you know, if somebody is struggling and they're looking for help,
Okay.
I mean, literally, it's a phone call away. It's
Yeah.
not hard to reach a live person
Okay.
who can help with care navigation.
That's great. Yeah, I think anything you want to send me, I can
Yes.
provide, or I'll list it in the comments, and it's been great.